So, the class outcomes for lower airway disorders, we will apply the pathophysiology of the lower respiratory tract to clients that are presenting with these lower respiratory disorders, these chronic airway diseases, and we will identify the importance of performing a complete health history and assessment. And this is of the utmost importance because we need this health history and we need this assessment in order to properly care for our client. A lot of their treatment plan will come from this health history and then our clinical assessment. And we will determine the possible complications associated with lower airway disorders or chronic airway disorders, because we need to be aware of complications. We need to know what's going to happen if we do not manage our clients properly. So, we will identify the clinical manifestations of lower respiratory infections. We will develop nursing interventions for clients with lower respiratory disorders, because that is what we do. We are nurses and we intervene for our clients. We will develop nursing interventions for clients with exacerbations of chronic respiratory diseases or disorders, and we will develop teaching plans for clients with chronic respiratory disorders. So, all lower respiratory disorders negatively impact oxygenation, ventilation, gas exchange, and then tissue perfusion, because remember, we are down in the lower lobes of the lung now. We are no longer talking about ventilation. The air is able to get in, at least in the beginning stages, if your client is not experiencing an exacerbation. So we are talking about gas exchange, the act of respiration, and then tissue perfusion. Some lower airway disorders can be chronic and progressive, such as asthma and chronic obstructive pulmonary disease, which we also call COPD. They will require meticulous management and lifestyle adjustments to achieve maximum wellness, because a lot of the treatment plan is going to be based on lifestyle adjustment. All patients with lower airway disorders will require thoughtful nursing care, a lot of support, not only from the nursing staff, but from family as well, and education to best manage their disease. So we're going to talk about asthma, and we've talked about asthma before. We talked about asthma when we were doing allergic disorders, because asthma is a reactionary airway disorder. It is a reactionary air disorder, but we are talking about it here also because it affects the lower lobes. So it also affects approximately almost 17 million Americans, including approximately 5 million children. So this is quite common. It will affect women more than men, and internationally it is estimated that approximately 300 million people will suffer with some form of asthma. So this is not only us, the United States, but it is international, it is worldwide. So the number is estimated to grow by more than 100 million by 2025. The risk of death from asthma will increase with age. Risk factors include a family history. So again, we are back to obtaining that complete health history. Risk factors also include eczema and the presence of allergies such as rhinitis. And remember, we also talked about asthma and what happens with asthma when we were talking about allergic disorders. So reach back and think about allergic disorders. So, asthma is a chronic lung disease that is characterized by an intermittent, reversible, please know this, reversible airway obstruction resulting from inflammation of the lung's airways and a tightening of the muscles that will surround those airways. So this condition affects the bronchial airways and not the alveoli. So in this respect, yes, it does have somewhat to do with ventilation, but again, what is happening here is preventing that gas exchange. There is also airway obstruction and then bronchial hyperresponsiveness, bronchospasm or constriction of the small airways, and then underlying inflammation will be triggered by an exposure to an irritant or a risk factor. And when we were talking about this during allergic disorders, we were calling these triggers, and we are still going to call them triggers because this reaction is caused by a trigger. Something is causing this irritant. So risk factors will include many common things: cigarette smoke, mold, pollen, dust, animal dander, air pollutants, occupational irritants, viral infections, nasal polyps, allergic rhinitis. Remember, we just spoke about allergic rhinitis. Food and drug allergies, and also emotional stress, because emotional stress has a lot to do with clients that have respiratory disorders. So please know these risk factors. Please pay attention to them. Exposure to irritants trigger an inflammatory response. And as part of the immune activation system, IgE antibodies. Remember these? Remember these from allergic disorders. These antibodies will bind to receptors that will release these mast cells, causing degranulation, and then the release of inflammatory mediators such as histamine and then the leukotrienes. Reach back, ladies and gentlemen, reach back deep into your brain for when we are talking about allergic disorders, because we are looking at the same conditions again. So vasodilation will occur, which is going to increase capillary permeability. The airway is going to become edematous. And again, let's remember, the basophils and the neutrophils will increase, which are going to stimulate the production of mucus. This mucus is going to be thick, and it is going to cause a thickening of the airways, and then more bronchial hyperresponsiveness. This is a cycle. This is a cycle. It will go on and on until we break the cycle. The release of histamine will also cause a constriction and spasm of the smooth muscles that surround these bronchial tubes. So bronchospasm of the bronchial tubes will occur. It's going to cause further narrowing of the airways. So bronchospasms, mucus production, and edema will result in an obstruction to the flow of air into and out of the lungs. So in this respect, we are talking about ventilation. So after exposure to the trigger, the client will exhibit clinical manifestations such as wheeze, dyspnea, coughing, increased sputum, and then an increased respiratory rate, right? And all of this is going to heighten their anxiety, right? Because they can't breathe. They know they can't breathe. Client may also experience chest tightness and tachycardia, which may be secondary to a decreased oxygenation level. Now they're getting anxious, or if we have already started treatment, it might be a side effect of treatment with bronchodilators. But a classic sign, ladies and gentlemen, please listen up. A classic sign is the inability to speak in full sentences. So, diagnosis. Diagnosis and assessment will include a detailed patient history. We need to know how long have they lived with these symptoms? How do they deal with them? Have they had them since childhood? Do any other members of the family have this? Because we know that asthma travels in families. It lives in families. Diagnosis and assessment will include pulmonary function tests, chest x-rays, pulse ox readings, and then ABGs, arterial blood gases. Detailed patient history should include childhood illnesses, family history or allergies or asthma, smoking, are they smoking now? Have they ever been a smoker? Occupational history, what do they do for a living? Where do they work? And then exposure to environmental triggers. Do they like to work outside? Do they like gardening? Do they bring flowers into their home? Do they have pets? Do they have a fireplace? So diagnosis will also include the frequency of symptoms, triggers, or specific activity or time. So is this something that only happens in the morning? Does it only happen in the evening? Does it only happen in spring or fall? Do they have an allergic disorder? How long do the symptoms last? And what does the client do when they first notice these symptoms? How do they begin to handle their symptoms? Do they handle them at all, or do they just hope that they go away? So chest x-ray is done to rule out any other respiratory conditions and to monitor progressive changes in the chest. We want to know if we're doing a good job taking care of this client. Pulmonary function tests are a predominant feature in evaluating asthma because we have to know how well these lungs are working. There are a group of tests that we can do to evaluate the functioning of the respiratory system. Spirometry. Spirometry is a test that will measure airflow and then lung volume. So one of the major tests that doctor will order in the pulmonary function realm is the FEV1. And this is forced expiratory volume in 1 second. The FEV1 will measure the amount of air that can be forced out of the lungs after a full inspiration. And then this volume is measured at 1 second. So what happens is when they are going for this test, they are going to be instructed to breathe in as deeply as they can. And then we are going to measure the expired air for 1 second. Then we are going to take that measurement and we are going to compare it to someone who, well, we're saying here normal, but someone who maybe does not have asthma based on their same age and the same gender. And this is very similar to if you have children and you used to take your children to the pediatrician and we used to do the height and weight and compare them on the chart to every other child. My child was always the lightest and the shortest. But this is how we will compare. So a decreased result in this test of 15 to 20% below the predicted value for age and gender will buy them the diagnosis of asthma. Or after this test and we get that reading, doctor or the technician may administer a bronchodilator, and then we will repeat the test, and then an increase of 12% after administration of this bronchodilator will also buy them the diagnosis of asthma. So peak expiratory flow readings will measure the maximum airflow expired during a forced expiration. And then we can also look at the client's peak flow readings and compare their personal best reading where they are well and healthy and not experiencing an attack. They are feeling fine that day. And then we will have them compare that peak flow reading when they are in the throes of an exacerbation or what we call an asthma attack. So clients are encouraged to monitor their own peak flow values, and they can do this at home. If they have a peak flow meter, they can do this at home because nursing will have instructed them on how to do these readings. The reading done during an exacerbation is compared to a personal best, allowing the patient to recognize the severity of their respiratory distress. So, and then with all of this and discussing the treatment plan, one of the things we do is create an asthma action plan. And this plan is based upon the peak flow readings. So if your patient is very compliant with their medications and with monitoring their own symptoms and monitoring their peak flow values, they can gauge when they are beginning to not feel well because something will be off. They may not feel well that day even though they're taking their medications, but they may notice a slight change in their peak flow readings. Pulse oximetry is a non-invasive method of measuring oxygen saturation, and this we know because we do it all the time, especially in the hospital. It can be used to determine the severity of respiratory distress. Normal pulse oximetry value is between 95 and 100%, and we know this. Pulse oximetry monitoring detects desaturation of hemoglobin before the client will exhibit symptoms. And sometimes these asthma clients, they will have a pulse ox monitor in their home to be able to monitor themselves. Arterial blood gas monitoring is an invasive sampling of arterial blood to measure oxygenation of the blood, acid-base balance, and then the partial pressure of carbon dioxide, right? And all of this has to do with the act of respiration, right? We want to know if our patient is becoming acidotic. Arterial blood gases will identify the client's response to oxygen, ventilation therapy, and then these medications. So once asthma has been diagnosed, the disease will be classified on the basis of the frequency and then the severity of the symptoms. And they can be classified as controlled, everything is going well. Partially controlled, where we're still working on it, we're still trying to get that perfect treatment plan that will work for them. Uncontrolled, which is some days they're having good days, some days they're having bad days, some days they're having very bad days. And then there is the exacerbation, and then that is the day of the asthma attack. So, the client will be given an asthma action plan, which will assist with decision-making, not only their decision-making, but they can bring this information to doctor or when they call doctor. So the plan will identify the severity of symptoms on the basis of peak flow readings, on the basis of their medications, and how they are feeling. What are their symptoms? So treatment. Treatment will include assessment, right? Because that's what we do. We assess, we go back, we reassess. We also monitor. And this is also self-monitoring of your client. Control of the environmental factors. Have they gotten rid of their pet? Have they started sleeping with their windows closed? Are they taking measures at work if it's an occupational factor? Pharmacological treatment, are they taking their medications? And then education, because this is all about education, teaching them how to live with this disorder. Assessment will be similar to the process that we are going to use for diagnosis, which is information gathering, asking questions. Frequency of symptoms and triggers should be monitored, and this can only be done by the client. This is done by the patient. Pulmonary function tests should be conducted on a regular basis to track response to therapy. So doctor may say, we're going to start you on this medication, and I want you to come in for a pulmonary function test in 1 month, in 3 months. So if they come back in a month and the medication is not working, maybe we need to make some changes, and then I will see you in another month to see if we are doing any better. Peak flow readings, pulse oximetry, and ABGs in a very severe attack are utilized during an acute exacerbation to determine the severity of the attack. So controlling environmental factors is a necessary part of the education program. We need to know and we need to make sure that they get this education, and then hopefully when they go home, they will make the environmental changes that they need to keep their home safe for them. So irritant exposure should be reduced once the irritant has been identified. So if the irritant is a pet, have they gotten rid of the pet? If the irritant is something that is in the home, maybe a cleaning product that they're using, maybe a fireplace, maybe a wood-burning stove, all of this will have to be changed. If there is somebody that is smoking in the home, they need to know that they need to smoke outside. Environmental smoke is associated with increased symptoms and decreased lung function, and clients should be advised not to smoke because this is an irritant, or not to be exposed to secondhand smoke, because that will also be an irritant. So listen up, and let's listen up one more time. The client should be advised to be aware of the levels of air pollution and avoid outside activities if the levels are high. So if this is somebody who has outside environmental allergies, or if they are susceptible to air pollution, if the level is high, they need to know that they should not be outside conducting an outside activity if the number is very high, if the level is very high. Listen up. Clients should avoid fumes from wood-burning stoves, fireplaces, aerosol sprays, Strong's perfumes. All of these are going to be irritants to those airways. Animals, birds, should be removed from the home if they are sensitive to the dander. And please note, stress and depression can also be a factor that can precipitate an asthma attack. Because remember, and we know this, when we start feeling anxious, when we start getting all worked up, what is the one thing that happens? It affects our breathing. It affects our breathing pattern. So, medications. Pharmacological treatment is based on the client's classification and then the level of control. And remember, we said those classifications were controlled, partially controlled, uncontrolled, and then exacerbation. So this is how doctor is going to move them from one classification to another and hopefully get them controlled. The classification of severity determines the type of medications that are needed to best control the symptoms. Classifications of medications are anti-inflammatories, bronchodilators, and then the anticholinergics. Anti-inflammatories, which are typically inhaled corticosteroids, will reduce mucus production and that swelling, that inflammation, making the airways less sensitive and then less likely to react to a trigger and then begin the symptomatic process. Listen up, and let's listen up one more time. Bronchodilators, such as the beta 2s, will relax the bronchial smooth muscle, helping to open the airway, then decreasing the obstruction. However, in doing this, it will stimulate the fight or flight response. And if you have ever seen anyone who is experiencing this fight or flight response, it can be quite frightening because they get a look of panic on their face. They start feeling even incredibly more anxious than they were, and they want to bolt. They want to bolt out of the bed. They want to bolt out of the room. And if they are very, very sensitive to this bronchodilator, or if it has been a larger dose than they're usually used to, they will want to bolt from the building. So when they go home and they are taking these bronchodilators, these beta 2s, we need to educate them. Listen up, please, that the client should only take the prescribed number of doses per day. This is not a case where more is better. This is a case where more is less. The client should only take the prescribed number of doses per day. Anticholinergics are another group of bronchodilators, and they will relax the muscles around the larger airways or the bronchi. And again, let's think back to when we were talking about allergic disorders and those leukotrienes. So here, the leukotriene receptor antagonists are another class of drugs that may be used if more typical medications are not effective. And please remember that these leukotrienes are not steroids. They are not steroids, but they will inhibit the leukotriene-mediated inflammatory process. Because remember, what we're trying to do is we are trying to take down this inflammation as quickly as we can to open up that airway. Medications will also fall into two categories: long-term control medications and rescue medications. Listen up, ladies and gentlemen. Long-term control medications are used daily used daily, regardless of your client having symptoms or if they are feeling controlled. They need to know, I have to take these medications every day, no matter how I'm feeling. If I'm feeling great, it doesn't matter. I still have to take my medications. The most effective long-term control medications are going to be inhaled anti-inflammatories. The most effective long-term control medications are going to be inhaled anti-inflammatories. Rescue drugs are those medications that are used once an asthma attack has started and this is what we call an acute exacerbation. So your client is not going to feel well. Maybe they have been down this road before and they will recognize that they need to use their rescue medications. And these are usually short-acting bronchodilators. Now please remember, we just said that they can only take these bronchodilators the prescribed number of times a day. So once they take these medications and they are not feeling any better, then they need to seek treatment. Short-acting beta-2s are the gold standard because they are the most effective. So in rescue medications, these short-acting beta-2s are the gold standards. But they should be used for acute exacerbation only. Oral anti-inflammatories such as prednisone may also be used during an acute exacerbation. And then as the attack subsides, as your client is recovering, these drugs are going to be tapered off. They cannot be discontinued abruptly. They need to be tapered off. So, complications. If I don't do a good job with my asthma patient, what can happen? Status asthmaticus is an acute exacerbation that is unresponsive to the typical rescue treatment with bronchodilators even after repeated frequent doses. So, your client is in the throes of an asthma attack, an exacerbation, and then if they are not responding to treatment, to the initial treatment, which is always the bronchodilator, then doctor will say they have status asthmaticus, and this is an acute exacerbation. And this exacerbation can vary from mild to severe. They will have bronchospasm, they will have inflammation, there will be excessive mucus production, they will feel those mucus plugs, and then this will make the client feel their chest tight. They will have a wheeze, you will hear a wheeze. They will have a dry cough. They will be trying to cough up this mucus, but because it is so thick, it will not be able to move. They will have shortness of breath and then severe respiratory distress. This will result in carbon dioxide retention, which will result in hypoxemia and then ultimately respiratory failure. So if we do not control this asthma attack and it progresses from mild to severe, there may not be a good outcome for your client. So typical triggers include a recent onset of a viral respiratory illness, exposure to an irritant or the allergen, or sometimes exercising in the cold. Status asthmaticus is a life-threatening emergency requiring prompt medical response. Treatment will include oxygen, IV fluids, systemic bronchodilators, and then steroids to open the airways and decrease this inflammation to enable your client to breathe, to get their respiration going, to get that ventilation. Endotracheal. So, nursing management. The symptoms your client will exhibit during this asthma attack are related to airway obstruction, and they will include difficulty breathing, using their accessory muscles for respiration. You will hear a wheeze. Sometimes in the throes of a severe asthma attack, you will be able to hear an audible wheeze. You will not even need to use your stethoscope. You will be able to hear an audible wheeze, and that is very frightening. They will have an elevated pulse, an elevated blood pressure. They will have increased anxiety because they cannot breathe. They will also have increased anxiety if we have given them a bronchodilator, right? Because it will stimulate that fight or flight response. They will not be able to lie flat. Why you would want to have your client lie flat at this time, I don't know. They will not have the ability to talk in complete sentences, which, as we said, is a hallmark sign of an asthma attack. And they will have decreased peak flow readings. So some nursing diagnoses for your client will be ineffective airway clearance related to increased mucus production, bronchospasm, and fatigue. They are tired. Impaired gas exchange related to difficulty breathing and fatigue. However, the big issue here, which will start everything, is the ineffective breathing pattern related to anxiety. Once their anxiety gets heightened, once they realize they are heading into an asthma attack, it will create this ineffective breathing pattern, and then it will just cycle from there. So ineffective breathing pattern is the basis for all of this. So nursing interventions. What are we going to do? Well, we are nurses and we assess, and then we're going to reassess again. So increased pulse rate may be a sign of poor oxygenation or anxiety as a side effect of treatment with bronchodilators. Because remember, we said these bronchodilators can actually help the situation, but in doing that, it can give them anxiety and that flight or fight response. Increased temperature will be a sign of infection. Respiratory rate greater than 30 breaths per minute is due to increased anxiety, increased work of breathing, that ineffective breathing pattern due to bronchial constriction. Peak flow values will indicate the severity of the asthma attack and will help monitor recovery. Listen up, listen up, listen up one more time. Use of accessory muscles. Once your client starts using these accessory muscles, they are demonstrating muscle fatigue. They are getting tired. Something that your client always wants to do when they are in this throes of this asthma attack is they always want to assume the tripod position. The tripod position is where they want to lean over a table, lean over a chair. They want that hunchbacked breathing position because they assume that it helps them to breathe. So they may assume this tripod position in an attempt to decrease the work of breathing. We are going to monitor their difficulty breathing. We are going to monitor their breathing pattern. An oxygen saturation less than 90% will indicate significant oxygenation problem. This hypoxemia will cause restlessness, anxiety, increased blood pressure, increased pulse rate. They are going to be anxious. So not only are they going to have this anxiety because of the medications and what the medications may be doing, but also because of the difficulty breathing. So their blood pressure is going to be elevated, their pulse rate is going to be elevated. Listen up some more. Arterial blood gases. As respiratory difficulty increases, we know that our client is going to be developing respiratory acidosis, right? Never a good thing. Never a good thing for our client. Breath sounds. You are going to assess their breath sounds. The presence of wheezing will indicate narrowing of those airways. First, you will hear expiratory wheeze first, and then that will progress to inspiratory wheeze. So first, when I'm breathing out, I will have constricted airways. And then, oh my, if we can't reverse that, then when it is not only when I'm breathing out, but also when I am breathing in on inspiration. Inaudible or diminished breath sounds will signify a decrease in the movement of air due to the increased obstruction of these constricted airways, and then respiratory exhaustion. They will not have the ability to speak in full sentences, and then this is also an indicator of respiratory distress. They will have a cough, They will want to cough because they will want to try and release some of that mucus or that mucus plug. There may be a change in their level of consciousness, and this may be an indicator of hypoxemia. So, and as we have said in the past, as I have said in the past, if it has happened once, there is a chance that it can happen again. So, if there has been a need for intubation in a past asthma attack, that is the indicator for me that this client has already gone down that road. It has already been that severe for them once, so it is a possibility again. So, if they have had a previous intubation, there is a chance that they may need to be intubated again. So, nursing actions. What are we going to do for this client? We are going to give them oxygen. We're going to provide oxygen. We are going to administer those bronchodilators as ordered, only as ordered. Administer anti-inflammatory medications and then steroids if necessary. Those anticholinergics to relax the muscles around the larger airways or the bronchi. And then, after everything is said and done, after they have recovered from this asthma attack, patient education, lots of teaching. We are going to provide the client with an individualized written action plan that will include daily management of asthma and how to recognize these symptoms and then what can lead to an exacerbation. So hopefully, if they can recognize early enough, they will not end up with an exacerbation. Control of asthma over time will require regular assessment, not only by you, but by the client. They will need to assess themselves daily, sometimes more than once a day, and then consistent management. And here you will have a slide of an asthma action plan. And initially, the client will fill this out with doctor, or they will fill it out with nurse. And so this is where the education will come in. And so when you can see that you're moving from the green zone into the yellow zone, that's how I know that my asthma is getting worse. And then what do I do? What do I do when I am in the yellow zone so that I do not progress to the red zone and then have to seek treatment? Right? What can I do? So this gives your client control over their disease process and control over how they can manage this disorder. It's a very, very important tool. So we also need to educate them on how to avoid their risk factors. Pursed lip breathing. Teaching your client how to perform pursed lip breathing is an invaluable tool. Invaluable to this client. Pursed lip breathing will keep the airways open longer because it will prolong that exhalation, allowing for increased time for oxygenation and then carbon dioxide exchange. It is an invaluable tool. Not only that, once they start practicing this breathing, it will help them with that ineffective breathing pattern, and it may also help reduce their anxiety and maybe give those bronchodilators, those rescue medications, a chance to work more effectively. They need medication education, always medication education. They should be educated on every single medication that they are taking. They need to be educated on their peak flow meter, how to monitor that pulmonary status. Doctor will help them establish a baseline, and then in the hospital setting, when they are going through their exacerbation, what that reading is to determine the value between the two and what is the severity of my respiratory distress. Smoking cessation. I cannot say enough about this. If they are smoking, they need to stop. And we've already talked about smoking cessation when we were talking about upper airway disorders. So please keep in mind all of that information moving forward. Proper inhaler technique. We have talked about this in respiratory skills. And if you have been in the clinical area and if you have given medications with an inhaler, you should know. You should already have this information, but if you do not, there is information in your book on page 481. Also, you are going to teach your client on how to care for their respiratory equipment, how to take care of that peak flow meter, how to maintain it, their nebulizer, their meter dose inhalers. They all need to be clean and kept free of infection. So how do I know? How do I know if I've done a good job in caring for this client with asthma? A well-managed asthma client has decreased visits to the emergency department and decreased need to use his rescue medications. He is more controlled. There will not be that time where, oh my gosh, I'm having a bad day and I have to use my rescue medications. The client will have minimal symptoms during the day and at night. And in order to accomplish this, the client has adequate knowledge. I have done a very good job with my patient education to help him manage his disease. The client has stopped smoking, or if there are people that are smoking in the home, they are smoking outside so that your client is not exposed to that secondhand smoke. He has made his home and environment as allergy-free as possible. He is no longer using the fireplace, no longer using the wood stove. He is sleeping with his windows closed. He is monitoring his peak flow readings once a day, twice a day, whatever doctor has advised. And he is adhering to his asthma management plan, that action plan that we devised in the office. He is following the treatment plan. He will delay the progression of his asthma, and he will have fewer exacerbations, and he will have longer and longer periods of times where he is asymptomatic because he is so controlled. Okay, so chronic obstructive pulmonary disease, otherwise known as COPD, is composed of two diseases: emphysema and then chronic bronchitis. And this condition, or one of these conditions, is the fourth leading cause of chronic morbidity and then mortality in the United States. So it is projected to be the third leading cause of death by this year, and it is projected to rank fifth in all diseases worldwide. So it is becoming more and more and more common. So right now, approximately 13.5 million people in the United States 18 years and older are estimated to have one form or another of COPD. So lung function tests will show that approximately 24 million people may have this disease, indicating that there is actually an underdiagnosis of COPD. So that number is going to change, right? And so what does that mean to you? Well, that just means that there are many, many people out there that have one or other, either emphysema or chronic bronchitis, that are living with this disorder. Prevalence is higher among women than men, and I guess it should go without saying that cigarette smoking is the primary cause of COPD. So approximately 80 to 90% of COPD deaths are caused by smoking. So COPD, lung condition, smoking, nothing new for us. We have heard all of this before. Some other risk factors will include occupational dust and chemicals, outdoor air pollution, and then secondhand smoke. So what is COPD? COPD is a disease that is characterized by airflow limitations. Airflow limitations. The airflow limitation is progressive, and it is associated with an abnormal inflammatory response of the lung to noxious particles or gases. So again, we are back to an inflammatory response. It is composed of two pulmonary diseases, emphysema and then chronic bronchitis. And both of these diseases will cause obstruction to the airflow, but in different ways. So if you are looking at this slide, and at the top left, you will see a normal lung. And you will be able to see the alveoli, and you can imagine how the gas exchange would be on a normal lung with no issues. So lower left is a lung with chronic bronchitis, and there you can see increased mucus, you can see the narrowing airway, you can see the thickened wall. So this has to do with the bronchial wall, the bronchioles that are leading to the alveoli. Whereas if you look at the lower middle, you can see a lung that has emphysema. And here, the bronchial wall, although showing a bit of damage and thickening, no, that's not the true problem. The true problem is the alveoli that has lost the elasticity. And once it loses the elasticity, then there is no way for that gas exchange to take place. So chronic bronchitis affects the small airways and is defined as the presence of cough, sputum production for at least 3 months consecutively in each of 2 consecutive years. So someone who has that lingering cough for 3 months, 2 years in a row, if investigated, would be diagnosed with COPD or chronic bronchitis. So just on that criteria alone, I know many people that are probably positive for COPD, but have not been diagnosed. So chronic bronchitis is caused by an inflammation of the bronchi and the bronchioles. The inflammation causes an increase in the production of mucus cells, which produce a large amount of thick mucus. So the walls of the bronchus will thicken and then cause airway destruction or obstruction. So smaller airways are usually affected before the larger airways. So just let me say now that the sputum, this mucus, is key in taking care of this client, because once that sputum begins to change, either it gets thicker, if it is clear, it turns white and then turns yellow. That is the clue that there is something going on with them and they need to get in front of that. Emphysema, on the other hand, is caused by the destruction of the alveoli. So the client with emphysema will lose lung elasticity and develop hyperinflation of the alveoli. So that will impair the gas exchange. Carbon dioxide cannot leave the alveoli and oxygen cannot enter, resulting in an ineffective exchange of oxygen and then carbon dioxide. So the client will have carbon dioxide retention and then chronic respiratory acidosis. And this is why when we are talking to you about these clients with COPD and we talk to you about giving them oxygen, this is the reason why they are already retaining carbon dioxide. So to give them more oxygen would truly impair their drive to breathe, and we will harm them. The manifestations of chronic bronchitis are different from the manifestations of emphysema. Because of hypoxia, these clients with chronic bronchitis will appear cyanotic, and we call them blue bloaters. Blue bloaters. And the way that I remember this is Cyanotic is a C. Chronic bronchitis is a C. They will have excess mucus production with a productive cough. Their earliest symptom, their very earliest symptom, will be a chronic morning cough with clear sputum. And so there are distinctive characteristics to both of these conditions, and there is a table on page 483 that you can refer to. COPD is characterized by exacerbations that can occur after exposure to pollutants such as smoke, respiratory infections such as a cold or a flu. So an exacerbation, as we have spoken about before, is a change in the natural course of the disease evidenced by a variation from the client's baseline day-to-day symptoms of difficulty breathing, cough, and or sputum. So they need to be self-aware. Again, this is a client that needs to be self-aware of their baseline, and they need to know, I'm a little short of breath today, my cough is a little worse today, I'm noticing a change in my sputum. Typically acute in onset, and they may warrant a change in their regular medications if we can get to them early enough. Warning signs of an exacerbation will include increasing shortness of breath, now I have a wheeze, or I feel as though I have a wheeze, more frequent or severe cough, anxiety. Remember, these clients are always going to be anxious, but because of their symptomology, they become even more anxious. They're going to have difficulty sleeping, and they will have a decreased appetite. So, diagnosis of COPD is based on the patient history, on the physical assessment, the spirometry reading, and the client will report progressive shortness of breath. So this is the client who, when we are evaluating them, will say, some months ago I was able to walk to my mailbox and walk back in my door and I felt fine. And then what happened is I was able to walk to my mailbox and I had to rest a few minutes before I had to walk back to the house. Then I can walk to my mailbox, but on the way to my mailbox, I'm having a little shortness of breath and I have to stop and catch my breath. And then finally, one of the more recent times you may see this client, they will say, I used to be able to go to my mailbox and walk back in the door, no problem. Now, I can't even walk to my mailbox. So it is reportedly progressive. A chest x-ray is typically done to rule out other causes of respiratory distress. And again, spirometry is the measurement of the lung volumes and then the airflow. So again, there are two tests that are done with spirometry that are the forced vital capacity, the FVC, and then again, that forced expiratory volume in 1 second, the FEV1, the same FEV1 that we spoke about when we were talking about asthma. So, forced vital capacity, the FVC, is the maximum volume of air that can be exhaled during a forced expiration. So again, FEV1 is the volume of air that is expired in the first second, in that first second of maximal expiration after a maximal inspiration. So again, your client is going to take a really deep inspiration, and then they are going to forcefully exhale, and we are going to measure the volume of air for 1 second, and that is the FEV1. And we are measuring the lungs' ability to empty quickly. So diagnosis is based on both the value of the FEV1 and then the forced vital capacity. So clients with COPD will show a decrease in both FEV1 and the forced vital capacity, the FVC. So, as we just said, COPD is a chronic, progressive disease. So as the disease progresses, the FEV1 and the FVC will deteriorate, and exacerbations will become more and more frequent and more severe and life-threatening. Severity and progression is indicated by the degree of abnormality of the testing. And there is a table on page 484, that I would like you to refer to. So, the treatment. What are we going to do for these clients? The management plan for COPD has four goals. To assess and monitor the disease, helping the client to reduce their risk factors, make them stable with their COPD, and of course manage their exacerbations, right? We want to keep them as healthy as we can. Assessment will include regular pulmonary function tests, chest x-rays with an exacerbation to identify whether there are any other thoracic abnormalities or progressive changes within the structure of the lungs. Is this really, if there is an exacerbation, am I really seeing just an exacerbation of their COPD, or now do we have a new problem? This will include pulse oximetry to determine the severity of hypoxemia during an exacerbation. And we would want to know this, right? We want to know exactly how low their oxygen level is dipping. Treatment will also include ABGs to measure oxygenation, ventilation, or the lung's ability to clear carbon dioxide, as evidenced by the CO2 and acid-base balance, right? So, and an ABG is the most accurate way to look at this balance, right? Because we're taking blood. It's very accurate. ABGs can also help to identify the client's response to oxygen therapy and to medications. Sputum cultures are assessed to identify organisms causing an infectious trigger to an exacerbation, because we said that, right? We did say that a virus or an infection could actually be a trigger to this exacerbation. So by checking their sputum and doing a sputum culture, if there is a secondary infection, we can begin to treat that and lessen the exacerbation. Reducing risk factors includes decreasing or eliminating exposures to chemicals, dust, air pollutants, especially smoke. So, the single most significant strategy is smoking cessation, right? Here we are again, smoking cessation. And we have already talked about smoking cessation with upper airway. So please, if you need a refresher, please go back and look at the smoking cessation information. So managing stable COPD includes health education regarding the risks and then the warning signs of an exacerbation, right? Because we want to tell them what's going to put them at risk. Actually, they should be able to tell us what is putting them at risk if they have self-awareness. And then there are warning signs of an exacerbation. If they've already had one exacerbation, they know how it goes, and they should be able to tell you, I know that I'm heading toward an exacerbation. Oxygen therapy, moderate exercise as tolerated, and the mainstay of medical management, which is medications. So the cornerstone of pharmacological management are the bronchodilators, the beta-2s. Here we are again, same as with asthma, the beta-2s and then the anticholinergics that are used individually or together on an as-needed or regular basis to control these symptoms. So a way to evaluate the effectiveness of treatment and determine a course of therapy is to give a bronchodilator after the initial spirometry and then repeat the test. And we said this about asthma, right? The best way that we can know is to get a baseline. So we're going to do an initial spirometry test. We're going to measure the FVC, the FEV1. Then we're going to give the client a bronchodilator, and then we're going to do the spirometry test again. This will help to determine how the lungs respond to the bronchodilator or how the pulmonary obstruction is reversed with the medication. So this will tell us how efficient the medication actually is working for this client. So medication management progresses as the disease will progress. And we know this, right? Because it will be new symptomology. So we will start with inhaled bronchodilators on an as-needed basis. And then as the disease worsens, we will include some long-term bronchodilators. And then we will go to the inhaled glucocorticoids when and if the patient experiencing more frequent exacerbations. So identifying and then quickly managing exacerbations is essential because they can dramatically impair pulmonary function and speed up disease progression. Please remember, every time there is an exacerbation, first of all, scar tissue is going to be formed. Then second of all, these exacerbations are going to become more and more and more severe. So we are going to have to work harder and harder and harder, not only to get them through the exacerbation, but to halt the next exacerbation. Inhaled bronchodilators and oral glucocorticoids are utilized as well as antibiotics if the cause of the exacerbation is the infection. So we're going to do everything that we always do. We're going to use the bronchodilators, we're going to use the steroids, but if there is an infection, well, of course, we're going to add in an antibiotic. That only makes sense, right? Listen up, listen up, listen up one more time. The clinical manifestations presented by the client are due to airway resistance. Airway resistance. The increased work of breathing. This is hard work for these clients. And their increased sputum production. So, clinical manifestations will include a cough, sputum production, dyspnea, use of accessory muscles, that tripod position, and again, the inability to talk in full sentences. The inability to talk in full sentences. So again, this pursed lip breathing, this breathing tool is going to be very, very valuable for this client as well as the asthma client. Because what it will do is it prolongs their exhalation and gives a better chance for that exchange of gases at the alveoli level. And we need to control their anxiety, right? Because it's a vicious circle. It's a vicious cycle. They get anxious because they can't breathe. And then they get more and more anxious, and then they can't breathe because they're anxious. Nursing interventions. What are we going to do for these clients? We are going to assess. We're going to go back and assess again because we are nurses and that's what we do. And what we are going to monitor vital signs, and what we are looking for right now is an increased temperature because that will be a sign of an infectious trigger. There is an infection present. We are going to monitor their difficulty breathing. We are going to look at their O2 saturation. If it is less than 90%, it will indicate significant oxygenation problems. So, listen up, listen up, listen up, and then listen up one more time. respiratory rate. We are going to be monitoring this respiratory rate like it's nobody's business. Respiratory drive in COPD is hypoxemia. We want to avoid hypoventilation. So the respiratory drive in COPD is hypoxemia, not hypercapnia. If the client receives too much oxygen, it will blunt his respiratory drive. It will decrease his desire to breathe. Respiratory effort in a client with COPD is triggered by the decrease in oxygen, not an increase in carbon dioxide. So too much oxygen may cause a decreased respiratory effort. So therefore, oxygen should be no more than 1 to 2 liters per minute. It should be no more than 1 to 2 liters per minute. Please take note. Weight. We are going to look at their weight. Monitoring their weight will identify nutritional deficiencies. With prolonged increased work of breathing and then their decreased energy, the ability to eat decreases. First of all, they lose their appetite. That is first of all. And then second of all, what happens is it is very, very difficult for these patients to eat and breathe at the same time. They almost have to choose which one they want to do because breathing to them is very hard work. So we are going to monitor breath sounds, and the presence of crackles and wheezes may indicate airway obstruction. Crackles will indicate the premature closing of the airways. Again, listen up, listen up. Listen up one more time. Pursed lip breathing, again, a very important tool. Pursed lip breathing will keep the airways open longer. It will prolong exhalation. It will allow for increased time for that oxygen and carbon dioxide exchange. And please remember, if we do that, we will help the patient avoid acidosis. And then we are going to look at their cough. Cough is a cardinal sign of pulmonary disease. So nursing management, nursing actions, we are going to administer bronchodilators as it is ordered, because bronchodilators are the smooth muscle relaxants that will help to open this airway. We are going to provide oxygen, but not too much oxygen, not more than the 1 to 2 liters, to increase the SpO2 to 90%. We are going to provide small, frequent meals, dietary supplements if necessary. Small, frequent meals, because this will be better for them. They can snack, they can graze. They're not dealing with a large meal, and it is better for their breathing process. Small, frequent meals take less energy to consume and avoid excessive pressure on the diaphragm that is associated with a large meal. And we know how this feels, right? Thanksgiving, Christmas, maybe you go out and you have a nice dinner with your family, or, well, not these days anyway, but, or maybe you go out and you have a nice dinner with friends and you're like, oh my gosh, I'm so full, and you want to sit back and you're trying to get comfortable in your clothes, and because there is a lot of pressure on that diaphragm. Adequate fluid intake is at least 2 to 2.5 quarts daily, and we do this because we want to make sure that that sputum stays thin. We want to make sure that they can excrete these or expectorate these secretions. Positioning, the semi-Fowler's position will increase oxygenation by allowing adequate lung expansion, but remember, these clients are going to want to assume that tripod position. So patient education, listen up, listen up, listen up one more time. What are we going to teach these clients? We are going to teach them about the pursed lip breathing, that long exhalation. We are going to talk to them about energy conservation, pacing activities. If they need to go into the kitchen, let's go into the kitchen. Let's do everything that we need to do into the kitchen, and then we can go back and sit down maybe in the living room, in the family room. This way, they are not going into the kitchen and performing a task and going back and sitting down, and then going back into the kitchen and performing a task and then sitting down. Let's talk to them about energy conservation. Smoking cessation. Smoking cessation is key to managing COPD, and it can change the course of the disease. Please listen up. Smoking cessation is key to managing COPD and can change the course of the disease. And again, I will remind you about the small, frequent meals. Medications, listen up, listen up, listen up one more time. Medication regimen, they need to know the medications, and they need to know why they're taking these medications. Why am I taking this medication? Does it matter? What is it going to do for me? And then lastly, you are going to talk to them about vaccines. The pneumococcal vaccine and then the annual flu vaccine will decrease the risk of disease exacerbations due to respiratory infection. So, recognition of symptoms of exacerbation. The client and the family should be aware of signs that will signify the client's respiratory is more impaired. So not only do you have to explain to the client, but you will also have to explain and educate the family on what to look for and how to assess. And then lastly, coping strategies, because the client and the family should be aware of the lifestyle changes that may occur because this family member has COPD. So these include an inability to maintain an active lifestyle. They may not be able to be as active as they once were. An inability to care for oneself. They may become depressed. I cannot do as much as I did before, and it's all because of my lung disease. Denial, and then social isolation. So strong support and effective coping strategies are essential to managing the lifestyle changes that this client is going to have to make in order to be successful. So some nursing diagnoses are impaired gas exchange related to altered oxygen delivery and alveoli destruction. Ineffective airway clearance related to decreased energy, difficulty breathing, and then an ineffective cough. Activity intolerance related to fatigue and shortness of breath. Anxiety related to breathlessness. And here we are again. Listen up, listen up, listen up one more time. Ineffective breathing pattern. Here it is again. It all begins right here. Ineffective breathing pattern that will be related to an elevated blood pressure. Elevated blood pressure, why? Because this client is trying just so hard to breathe. It is such hard work for them. And fatigue because they are tired. So the nursing diagnosis would read ineffective breathing pattern related to elevated blood pressure and fatigue because this is hard work for this client. Listen up, listen up, listen up. Evaluating care outcomes. How do I know that I have done a good job in taking care of this client? Well, a well-managed client with COPD has decreased visits to the emergency department and hospitalizations because they are compliant with their medications. They understand why they're taking them. They are aware of their triggers. They are monitoring their sputum. They are controlling their exacerbations. So the client will have adequate knowledge to manage his disease. There is medication compliance and avoidance of people with colds or flu that may increase the risk of exacerbation because I don't want to develop that secondary infection. And smoking cessation is successful and healthy dietary habits are maintained by eating those small, frequent meals. So, lung cancer. The American Cancer Society will indicate that lung cancer is the second most common cancer in both men and women. It is also the #1 cancer killer in the United States for both men and women. And overall, women will have a lower rate than men. So, lung cancer, if diagnosed with a stage 1A lung cancer, the survival rate is 49%. If diagnosed with a stage 4 lung cancer, the survival rate is 1%. So, what do we know here? We know that early diagnosis is key. This is due to the fact that when diagnosed with stage 4 lung cancer, the disease has already spread to lymph nodes and other organs. And this is most prevalent in persons that are over age 65. And of course, the major cause, almost approximately 90% of cases, is due to smoking, which is the most preventable cause there is. So the risk will increase as the number of cigarettes smoked and the length of time spent smoking will increases. Listen up, listen up, listen up. The risk factor of someone who quits will be dramatically less than someone who continues to smoke. Does not this make perfect sense? That if you are a smoker and you decide to quit, your risk factor will be that of less of someone who continues to smoke. Other risk factors will include secondhand smoke, radon, occupational pollutants, and asbestos. So, lung cancer is caused by the uncontrolled growth of abnormal cells in the lungs. There are two types: non-small cell and then small cell. Non-small cell cancer represents approximately 85% of lung cancers and will consist of 3 different types of cells. They are squamous cells, adenocarcinomas, and then the large cell carcinoma. There is a 5-year survival rate for those diagnosed with non-small cell cancer if it is diagnosed early. So early is good. Small cell cancer, called oat cell, represents approximately 15% of lung cancers. It is a very quick growing cancer, and it will mets to other organs in the body just as quickly. Independent of stage at diagnosis, survival statistics are poor because it kills quickly. Only approximately 5 to 10% of those developing a small cell cancer will survive for 5 years. So, clinical manifestations are not typically apparent early in the disease, right? But they will become apparent, of course, as the disease advances. Clinical manifestations will include a new cough that does not go away, or changes in the chronic cough, hemoptysis, shortness of breath. They develop wheezing, hoarseness, and we talked about this with laryngeal cancer, that hoarseness that will last for 2 weeks or more with no significant cause, and chest pain. Headache and bone pain may also be present. Weight loss is very common, and as would be expected, the symptoms become progressively worse as the disease progresses. So, diagnosis is done through several methods. We can do a simple chest x-ray. Well, of course we can. However, listen up, listen up, listen up. A CT of the chest, will be used to evaluate and localize tumors. It can also detect distant tumor mets and evaluate tumor response to treatment. So in this respect, a CAT scan of the chest is the most reliable, the most valuable. We can also do a sputum for cytology. We can do a bronchoscopy. We can do a PET scan. Doctor may order bone and abdominal scans, or we can perform a mediastinoscopy. So, a chest x-ray or a CT of the scan of the chest may identify a pulmonary lesion. Sputum cytology test to identify specific tumor cells. Bronchoscopy or mediastinoscopy will allow direct visualization of the tissues to aid in the diagnosis of lung cancer. The bronchoscopy is the assessment of the lower airways, the trachea and the bronchi, through a scope that is inserted through the nose or the mouth, and we talked about this when we were talking about laryngeal cancer as well. However, a mediastinoscopy is a surgical procedure that will allow for the direct visualization of the mediastinum. A scope will be inserted through an incision in the chest that allows direct examination and collection of samples for biopsy. Bone and abdominal scans are done to look for METs, and the PET scan can detect areas of increased metabolic activity as occurs with rapidly dividing cancer cells. So, non-surgical management. Treatment for lung cancer is multidisciplinary, and it depends largely upon the type, the size, the location, and then the stage of the tumor when it is diagnosed. So, non-surgical management, or any type or management period, will typically consist of a combination of things. We can do surgery, we can do radiation, we can do chemotherapy. However, the most important thing we need to think about is pain management. Pain management is an important focus in treating this client. The chemotherapeutic agent that is used to treat lung cancer is dependent upon the type of tumor that is involved. So, chemotherapy can sometimes be given before surgery to shrink the tumor to aid in the resection. So we would call this a neoadjuvant therapy. Or it can be used as an adjuvant therapy after surgery to kill any of the remaining cancer cells. It may also be the main treatment option for the more advanced cancers, or if the client is too ill for surgery. These are all chemotherapeutic options. Radiation can be used if surgery is not an option because the tumor cannot be removed. Radiation will also be used to shrink the tumor before surgery or after surgery to kill any of the remaining cancer cells. Radiation can also be used palliatively to relieve symptoms or for pain control. This is when we know I am not going to fix this client. I am not going to fix them. I am not going to make them well, but I can make them comfortable and I can help to control their pain. So we will continue to do radiation in order to help control the pain. But I know that I am not doing this to try and save the life. Because, and as we said before, pain control is a major factor in lung cancer management. So the World Health Organization has developed a pain relief ladder that is used as a guideline for pain control. So in step 1, we are using non-opioid analgesics such as Tylenol or NSAIDs, and we will use these for mild to moderate pain. Step 2 will consist of a moderately potent opioid such as codeine, hydrocodone, oxycodone, plus that non-opioid for persistent pain that is not controlled by step 1. And then step 3, we will include the use of a stronger opioid, morphine, fentanyl, plus another non-opioid for uncontrolled or severe pain. So, and at all levels, Adjuvant or additional drugs should be given to relieve client anxiety, because these clients will be very, very anxious, and this will affect their breathing pattern. Pain medication. Listen up, listen up, listen up. Pain medication should be given around the clock rather than on demand to avoid peaks of pain. These clients are in incredible pain. It is unfair of you to ask them to ask for their pain medicine. Give it around the clock. Palliative care services are appropriate to consider from the diagnosis to the life-threatening illness, such as lung cancer, through the course of the disease. So palliative care will improve the quality of life for the client and their family. Palliative care can also help in management of other distressing and debilitating symptoms that they will experience, such as shortness of breath, nausea, and vomiting. So, surgery is the preferred treatment if there is no METs. If there is no METs, then doctor will consider surgery. It is primarily used for non-small cell tumors, and there are several types of pulmonary surgery that we can do depending on the tumor site and the size and what doctor feels is appropriate. So here you have the various lung surgeries. You can have the lobectomy. The lobectomy is the removal of the entire lobe of the lung. That is the slide that you will see. That is the picture that you will see on the left. In the middle, you will see a pneumonectomy. A pneumonectomy is the removal of the entire lung. And on the right, you will see a wedge resection. And a wedge resection is the removal of the small section of the lobe of the lung that is affected. So, nursing management. The client with lung cancer will present with the following characteristics as a result of abnormal cell growth and then tumors in the lungs causing impaired chest movement, and then therefore impaired air exchange. They will include a persistent cough, difficulty breathing. They will be wheezing, and then hemoptysis. They will have chest pain. There will be frequent episodes of pneumonia or bronchitis. So, nursing interventions. What are we going to do for these clients? We are going to assess. We're going to go back and reassess and then assess again. And we are looking at temperature, and we are looking at an increased temperature to be the sign of an infection. We are looking at oxygen saturation. Decreased O2 is due to poor gas exchange. So an SpO2 of less than 90% again will indicate significant oxygenation problems. We are looking at their appetite. We are going to monitor their weight. Appetite may be decreased because of the side effects of chemotherapy or loss of energy due to increased work of breathing. So monitoring their weight will identify nutritional deficiencies and also tell us how tired they are getting, right? To monitor. Breath sounds. We are looking at breath sounds. The presence of wheezes may indicate airway obstruction, so rhonchi will indicate increased secretions in the upper airways. We are looking at their cough. Cough will indicate an irritation of the tracheobronchial tree. Pain. We are going to monitor for pain because pain will increase their respiratory rate, it will increase their anxiety, and of course, it will decrease the quality of their life. So what are we going to do for these clients? We are going to administer medications as ordered. We are looking at pain medications. We are looking at anti-anxiety medications. Pain and anti-anxiety medications will provide relief from both pain and anxiety, allowing them to relax. They will be pain-free. They will not be anxious. And if all of that happens, then what happens? They are able to breathe more efficiently. Bronchodilators will relax those smooth muscles in the bronchial tree, opening the airway and decrease the work of breathing. We are going to give them oxygen if necessary. We are going to provide them small, frequent meals because energy is being used for breathing. Sometimes they don't want to spare their energy to eat. So small, frequent meals where they can graze throughout the day is better for these clients. And then a semi-Fowler's position. So, patient education, what are we going to teach these clients? We are teaching them breathing techniques, controlled breathing. Again, they are going to have an ineffective breathing pattern. So by controlling their breathing, it will help to increase the clearance of sputum. It will reduce their breathlessness. Again, pursed-lipped breathing will encourage the exchange of oxygen and carbon dioxide. We are going to talk to these clients about energy conservation because conserving energy will reduce the work of breathing for these clients. If they have not done it yet, we are going to talk to them about smoking cessation because smoking cessation can change the course of this disease process. Listen up, listen up, listen up. Smoking cessation can change the course of the disease process. We are looking at nutritional needs, small, frequent meals that will decrease the work of breathing with less impact on the diaphragm. Medication regimen. They need to know their medications. They need to know why they're taking their medications. They need to know how to use their inhalers. And they have to have some control over the ability to manage their disease. And of course, listen up. Pain medications around the clock. So, So a wide variety of pathogens can produce infection from the respiratory tract, including bacteria, viruses, and fungi. As environmental air is inhaled, the first line of defense lies within the upper respiratory tract. And we remember this, right? We remember this from when we were talking about the upper respiratory tract. And the upper respiratory tract consists of the nasal cavities, the pharynx, and the larynx. And then the nasal cavities are lined with epithelial tissues and blood vessels that will filter and warm the inspired air, right, before it gets into our body. So the surface epithelium will secrete antimicrobial peptides that will exert a bactericidal effect on a variety of pathogens, right? So these are bacteria lining our bodies so that as things are passing through, if it is a foreign body, if it's something that the body is going to consider a foreign body, it is going to want to destroy it. The endothelial lining of the nasal cavities will contain hair-like projections, and we remember this as cilia, that through their wave-like motion transport any particles trapped by the mucus lining back into the nasopharynx and the oropharynx. And then in doing this mechanism, this defense mechanism, is called the mucociliary escalator. And then this particular matter is expelled from the body in a protective measure by either us sneezing or coughing. So, additional protective mechanisms of the upper respiratory tract are provided by the colonization, and a colonization is a collection of a number of bacteria that are small enough not to cause infection. And so, additional protective mechanisms of the upper respiratory tract are provided by the colonization of resident bacteria and then some viruses. Examples of resident bacteria and viruses include Staphylococcus, Streptococcus, spirochetes, Mycobacteria, Pseudomonas, Proteus, and Enterococcus. So this normal flora will function to maintain a healthy respiratory tract by competing with pathogens for attachment sites in the respiratory mucus lining, and then again producing those bacterial substances that will destroy harmful microorganisms. So all of this is working to protect us from these pathogens. So a layer of ciliated cells along with the mucus secreting cells within the trachea, bronchi, and bronchioles will protect the lower respiratory tract via this mucociliary escalator from smaller sized particles that have avoided the upper airway defenses. So now we also have a layer of ciliated cells along with everything that is happening in the upper respiratory tract to also try and protect us and filter. The lower respiratory tract houses no resident flora. No resident flora. Now we did say that the upper respiratory tract had bacteria up there, that was good bacteria to help us protect ourselves against these pathogens, but the lower respiratory tract does not. It houses no resident flora and is considered a sterile environment. So this is due to the efficiency of the upper respiratory tract ciliated epithelial lining in eliminating the majority of inhaled pathogens. So it is the upper respiratory tract defenses that are going to do the majority of the work. However, should pathogens gain access to the lower portion of the respiratory tract where the alveoli live, alveolar macrophages are the most important means of limiting microorganisms from this area by phagocytosis. So if something does in fact happen to work its way all the way down to where the alveoli are living, there are macrophages down there that are going to try and destroy these pathogens by phagocytosis. So again, trying to keep the body safe. So it is of the utmost importance that the alveoli remains free of pathogens because it is here that the exchange of gases occurs. It is here on the alveoli that respiration will occur. It is only when the respiratory epithelium becomes damaged or the sheer number of inhaled pathogens exceed the ability of these protective mechanisms to function that we in fact develop a respiratory infection, a respiratory cold. So you have to understand that we do have a lot of bodily defenses in order to maintain homeostasis. There's a lot of defenses working to keep us safe. So these pathogens really have to work very, very hard in order to get all the way down into that lower lobe and escape all of these defenses in order to give us an infection. So, and here what you are seeing is that exchange at the alveoli wall, the exchange of gases. So, in order for a respiratory tract to be fully established in the lower respiratory tract, in order for a respiratory infection to be fully established in the lower respiratory tract, the following barriers must be avoided, and then these conditions must be met. There needed to be avoidance of trapping in the mucociliary layer of the upper respiratory tract, so they would have had to escape all of defenses in the upper respiratory tract. Avoidance of the phagocytic action of the alveoli macrophages in the lower respiratory tract. So they would have to have escaped everything in the upper respiratory tract, worked its way down to the alveoli level where this phagocytosis is going to occur and escape that. Infectious organisms must be airborne and have the ability to remain virulent while in the air. So this means that they have to be strong enough, it has to be a strong enough organism that it can live a long time. and then there must be sufficient numbers of infectious organisms inhaled and deposited on susceptible tissues within both the upper and the lower respiratory tracts, which means that I am going to think about this now, especially in terms of what we're going through now with COVID-19, that we have to be close enough to somebody where somebody is either going to cough or sneeze, because that would constitute a large number, a sufficient number of infectious organisms, right? So somebody's going to cough, somebody's going to sneeze into the air. Those organisms are going to be strong enough, virulent enough to hang in the air and live in the air. And then here I come along and I'm walking through the cold, their sneeze or their cough, and I'm going to breathe that in. And then, because it's a sufficient number, it will be able to escape the upper respiratory tract defenses, work its way all the way down to the lower respiratory tract, escape phagocytosis in order to give me a respiratory tract infection. So, once these pathogens have been established in the respiratory tract, then that is going to initiate the inflammatory response, right? And here we are back with the inflammatory response. So, because this is now systemic, neutrophils, and everybody remembers what neutrophils are, they're the little baby white blood cells. They are going to be recruited by the body to come to the infected alveoli along with other immune cells and serum components, because now we want to try and fight off this infection. There will be an accumulation of fluid and exudate, providing the perfect medium for the proliferation of the infected organism. And then this will assist with movement to the other nearby alveoli. So now this organism really has a hold on me, and it is going to spread from the initial alveoli to other nearby alveoli. So fluid and exudate-filled alveoli are prevented from effective gas exchange at the alveolar capillary level, and then this will produce varying degrees of hypoxia depending on the severity of the infection. So you can see, and this is not, sometimes this can happen in a matter of hours, but you can see how this can happen over a matter of days. So you can see how you might not feel good, and then the next day you feel a little worse, and then the next day you feel a little worse, and then you're like, oh my gosh, I actually have a cold. You know, this has been a couple of days in coming. And if you remember, one of the things that my grandma always said, that when we were talking about colds and infections, she would always say 3 days coming, 3 days with you, and then 3 days leaving, which is about a week and a half. So we're going to start talking about influenza, right? And very appropriate, because here we are, right? It is the beginning of flu season. We are starting flu season. So influenza is a highly contagious infection that is rapidly spread from one individual to another. So it spreads very quickly, and we start feeling poorly equally as quickly. So flu outbreaks are tracked, and they are recorded annually, and they are reported by the Centers for Disease Control and Prevention, that is the CDC, because localized outbreaks that affect more than the expected population, they are called epidemics. So localized outbreaks that will affect a number of people in a specific area or a specific population are called epidemics. What we're dealing right now with COVID-19 is a pandemic, because that is international, it is worldwide. And influenza can occur at varying intervals, and strains will usually change, usually every 1 to 3 years. So there is substantial morbidity and mortality that can occur, predominantly among those who have underlying comorbid medical conditions. So if somebody already has something else like asthma, diabetes, or if they were very young, or a senior citizen, somebody who is in advanced age. So there are other predominantly risk factors that are outlined on page 444, and you can take a look at those, please. Human influenza viruses are divided into 3 types, and they are designated as A, B, and C. influenza A viruses are divided into subtypes, and this is based on differences in the two viral proteins, hemagglutinin H and neuraminidase N. So influenza B is not broken down into subtypes, but it can be categorized by different strains. Influenza types A and B are responsible for epidemics of respiratory illness that occur mostly during the winter months. That's where we are now. And they're often associated with increased hospitalizations and deaths. And yes, people do die from the flu, but usually because they have other comorbidities and they cannot recover. Most extensive and severe outbreaks are from influenza A because of the tendency of the H and N antigens to mutate. So it can overtake the respiratory system a little quicker. Seasonal mutations of the viruses cause the emergence of a new and different influenza virus and contribute to a new pandemic. And this is where we are. Not that COVID-19 is a seasonal mutation, but it is a virus that that we had no idea about. It's very new, very different, and so we are having trouble combating it medically, chemically, and this is where we are in this pandemic. So these mutations allow the virus to escape the immune system surveillance of its host, right? Making individuals susceptible to the mutated influenza infection throughout our life. So efforts to control the impact of influenza are focused on types A and B. Influenza C typically causes either no symptoms at all, or it is a very mild respiratory illness, and we could probably call this a cold. It is not associated with the occurrence of epidemics and does not have the serious public health concern that is associated with influenza A and B. So, the pathology, the pathophysiology of the flu. The primary event that will initiate an influenza infection is the aerosolization of small droplets. And we know this, right? It's in the air from an infected individual sneeze or cough or by direct contact with fomites that are inhaled and become deposited on the upper respiratory tract. So how does this happen? Well, again, somebody is going to cough or they're going to sneeze into the air, and then these droplets are going to hang in the air. They're going to live in the air, and I'm going to walk through their sneeze unknowingly. I'm going to walk through their cough, or they're going to sneeze, cough. It may be on their hands, or they might cough onto something. Then I'm going to come along. I'm going to touch it. I'm not going to wash my hands. I might touch something close to my face, and there we go. The cells are on their way. Over a period of approximately 4 to 6 hours, these infected cells reproduce and spread the virus to other respiratory cells, extending the infection throughout the respiratory tract. And this is the person who wakes up in the morning and they feel like crap. They absolutely feel like crap, and they don't understand it because yesterday they felt perfectly fine. So the incubation period, is the time the initial droplet inhalation we start our symptoms lasts approximately 18 to 72 hours. So not only can I become sick with this pathogen, but I can also give it to the rest of my family. I can pass it on to anybody that I am close to. So the severity of the symptoms and subsequent illness is dependent on the amount of viruses shed during the replication phase and the number of respiratory cells that are affected. And virus shedding will usually end 2 to 5 days after symptoms first appear. 2 to 5 days after symptoms first appear. So it is important to remember that individuals are infectious for up to 7 to 10 days, right? So I can pass this on for a significant amount of time. So clinical manifestations, what are you going to see? What is your client going to complain of? Clinical manifestations are more severe than those of a cold, and they will come on more quickly. Again, this is a person that, I felt pretty good, and then today I wake up and I don't feel well at all. Tomorrow I'm going to feel even worse. They will include fever, headache, sore throat, nasal congestion. They may have a cough. They're going to have those awful muscle aches and pains, the general feeling of being unwell, and they are going to be very tired. So how do we diagnose this? How do we diagnose this flu? The diagnostic gold standard is a sampling of respiratory secretions for a viral culture. The most significant drawback, however, to getting this culture and growing this culture is that viral cultures can take up to 10 days to provide confirmation that yes, in fact, you do have the flu. So by the time this culture is coming back, you are already on the mend, you are already starting to feel better, and then the doctor's office is calling to say, yep, you've had the flu, and you're like, geez, that's great, I feel better. So in emergency departments and in outpatient clinics, as minute clinics or urgent care, the most commonly utilized tests are called rapid influenza diagnostic tests, the RIDTs. So identification can be made in less than 30 minutes via this nasopharyngeal throat swab or nasal washings aspirate. So sensitivity and specificity of these RIDTs can be variable, and depending on the manufacturer's test and then the type of the virus, and also sometimes the technique that the specimen is collected, circulating during a specific outbreak. So a negative RIDT does not necessarily mean that there is no influenza. It could be a false negative test. So clinicians should make a diagnosis solely on the or they should not, excuse me, clinicians should not make a diagnosis solely on the basis of the test result, but should also consider the client's symptoms and the history and rely on clinical judgment. And this is true, right? Because I'm going to look, of course, I'm going to look at, the test result, but I really want to see, and I really want to get a health assessment from my client. I want to talk to the patient. So accepted influenza testing methods for types A and B are found on page 445 in your textbook. Circulating antibodies can be detected in the blood of individuals with an influenza infection within 2 weeks of initial infection. So 2 weeks after you become infected, you will begin to develop those antibodies to protect you moving forward. So, treatment. Now that we know that our client has the flu, what are we going to do? Well, treatment will be directed toward prevention by annual vaccinations. So, you have the flu this year, you're feeling really crappy. So you don't want to do this again next year. You don't want to feel as crappy. So let's make sure that you get your flu vaccine. Inoculation by inactivated influenza viruses that were identified as causing outbreaks the preceding year can provide up to 80% protection from the projected upcoming year's virus. So this means that the flu shot that you get this year is giving you 80% protection from the flu strain that was last year. So the influenza vaccine is based on the flu that we had last year. It is giving you 80% protection for this year. So side effects from vaccinations occur infrequently, and they will consist of a low-grade fever and then soreness at the injection site. And we know this, right? Because you always say, well, I went and I got my flu shot and now my arm is feeling a little sore. So individuals who have an allergy to eggs should not receive this form of vaccine because of an inactive egg ingredient of an egg protein. And we know this, right? Because whenever you go to get your flu shot, they ask you the series of questions. And one of the questions that they ask you is, are you allergic to eggs? So alternative forms of the vaccine without the egg protein are available. And that is the vaccine, if you have an egg allergy, that you will receive. So the most appropriate time of year for the vaccination is in the early fall, before the flu season begins. Because if it's going to take 2 weeks to build up those antibodies, that's what you want, right? You want to get to build up those antibodies before we actually get into flu season so that you can be protected, Medications, what are we going to talk about? Well, medications are directed toward the relief of the symptoms, right? Because this is a virus and we can't fix the virus, right? I can't control the virus. I can only manage the symptoms. So antipyretics, analgesics for fever and aches, adequate fluids to avoid dehydration from the fever, and rest. Lots of rest. So for the more serious forms of influenza or widespread local outbreaks, several antiviral medications will be available for prophylaxis or for treatment. So, the decision to treat flu symptoms utilizing antivirals is made on the basis of the severity of the presenting symptoms, how sick is the client, how sick is the patient, their overall health status. So if they have a lot of comorbidities, then they may benefit from taking these antivirals. The administration of these antiviral medications does not cure the flu. It will not cure the flu. Even though it's an antiviral, it will not cure the flu, but it can help prevent the respiratory tract from becoming further impaired. So the best results are achieved when antiviral medications are initiated within 24 to 48 hours of the beginning of symptoms. So this means that doctor is going to have to make a decision pretty quickly about giving these clients these antiviral medications, because they will only work best if they're taken within a day or two of the client getting the symptoms. And antiviral medications are described on page 445 of your textbook. So, complications. Primary influenza viral pneumonia is the least common, but it is the severest complication and occurs more frequently in individuals over the age of 65, and it does not matter if they have a chronic illness or not. These complications are marked by progressive shortness of breath because it is a respiratory illness, persistent fever because that bacteria is just replicating, and then cardiovascular compromise. Dyspnea and negligible sputum production that may be visibly blood-streaked is also associated with the onset of a secondary bacterial pneumonia. So now please remember that the viral pneumonia is going to come from the flu, because all of those secretions are sitting in the lung, and it's dark and it's wet and it's moist, and it's very good for multiplication. But now we are developing a secondary bacterial pneumonia, and you know what that means. So there are frequent bacterial organisms that are likely to set for secondary pneumonia, and they are Streptococcus pneumoniae, Staphylococcus aureus, and then Haemophilus influenzae. These organisms are resident normal flora within the nasopharynx that will become pathologic when the respiratory defenses are altered. And again, these are bacteria that have made it all through the defense mechanisms of the upper respiratory tract, the lower respiratory tract, and are now being replicated. So, secondary bacterial pneumonia classically presents as improvement in the viral symptoms, and we've talked about this before when we were talking about upper respiratory disorders. The client feels like they're getting better, they're getting better, they're getting better, and then all of a sudden there are going to be a recurrence of symptoms, and there's going to be purulent nasal secretions, so they're going to be blowing their nose, and the discharge is going to be colored, and then the tracheal secretions are going to be coughing up sputum, and it's going to be discolored. Sinus and middle ear secondary bacterial infections may also accompany an influenza viral illness. So, nursing management, what are we going to do? What are we going to do? What are we going to do? Clinical manifestations observed in the client with influenza: cough, headache, nasal congestion, a sore throat, fever, are typically the result of the inflammatory response once the virus has invaded the respiratory epithelium. So what we need to do is we need to assess, and then we need to go back and reassess. A sudden onset of fever chills, muscle aches, and fatigue in a generally ill-appearing client is a negative assessment. Neurological function, we are looking for agitation, we are looking for restlessness. There is going to be anxiety because this is a respiratory disorder and these clients may already be compromised and unable to breathe well. They're going to be lethargic, they are going to be tired. And this is all as a result of decreased tissue perfusion from altered alveolar gas exchange. So, vital signs. What are we going to see in vital signs? Tachypnea, the body's first compensatory mechanism to decrease oxygen delivery is increased respiratory rate. The body is going to want to breathe a little quicker because we're getting anxious and we want to get that oxygen into our body. So the first thing the body's going to want to do is it thinks that if I breathe faster, I'm going to get more oxygen. And tachycardia is the body's second compensatory mechanism for a continued impairment of oxygen delivery is to raise the heart rate, because now breathing faster is not working. So the heart says, well, let me help you out. And if I pump a little quicker, maybe we can get this oxygen in here. So what we will see is decreased oxygen saturation because of impaired gas exchange at the alveolar level. So it doesn't matter that the lungs are working harder, and it doesn't matter that the heart rate is going up. All of this is impaired gas exchange. Fever will occur as a part of the inflammatory response. And then we're going to listen. Breath sounds. Adventitious breath sounds such as wheezing, rhonchi, crackles, and rales may be audible on lung assessment from fluid and exudate that is filling the alveoli. Cough, nasal congestions, lots of sneezing, rhinorrhea. So primary viral pneumonia from influenza can cause coughing that will last up to 2 weeks. There will be purulent nasal discharge. There will be sputum that will indicate a secondary bacterial infection. Remember, once everything starts to become discolored, it is no longer a virus, and now it is bacterial. Peripheral pulses and skin temperature. Diminished tissue perfusion, because remember, there is very little air exchange, right? Because the alveoli are affected. So there's going to be very little or none air exchange. So when that happens, there is no tissue perfusion, right? Because there's no oxygen to send out to the body. So diminished tissue perfusion will cause the blood to be shunted away from peripheral areas to the main core body organs. So this means that the extremities, arms and legs, will be a little cooler. They're going to be a little paler because the body is trying to protect itself, and everything is going to, and all the blood available and all the oxygen available is going to go to the main core body organs. Lab values, what are we going to see? ABGs. Primary respiratory infections will cause respiratory acidosis, decreased pH, increased carbon dioxide. We are going to put these clients on isolation, droplet and contact precautions to avoid viral transmission, right? We want to make sure that we don't transmit this to anybody else. We're going to want to protect them. We want to protect everyone else. Administer humidified supplemental oxygen, improvement in oxygen delivery, reversing hypoxia, and maintaining a moist respiratory mucosa is essential to avoid complications. And then we are going to administer antipyretics as ordered and as it is indicated. Fever reduction can reduce hyperdynamic effects on the respiratory and the cardiovascular systems, and it will make your client more comfortable. Administer analgesics as ordered. Pain relief can cause comfort and allow for mobilization and effective coughing, because once they are comfortable, once they are no longer in pain, they can get up and they can move around, which is going to loosen those secretions. It will give them a more effective cough, and they will be able to expectorate those secretions. Administer antiviral medications if doctor has ordered them and if it is indicated for your client, but please remember, early administration of antiviral medications within those 24 to 48 hours of the beginning symptoms will offer the most favorable outcome for shortening the severity and duration of symptoms and will decrease the incidence of respiratory complications in your high-risk client population. Listen up, listen up, listen up, and listen up one more time. Positioning your client can be key. It can be key to helping your client feel better. So positioning the client in a semi to high Fowlers where the bed is raised at least 30 degrees, sitting up or elevating the head of the bed can provide for relief of this nasal drainage, and then it is going to promote this optimal lung expansion. And in doing this, they will better be able to cough and deep breathe, which can help prevent atelectasis. It can prevent aspiration that can lead to that secondary bacterial pneumonia. Adequate fluid intake, we are going to obtain cultures, nasal swabs, throat swabs, sputum, blood, urine, anything before we start these antiviral medications, because we want the antiviral medications to be very, very effective in what we are trying to combat. Good hand hygiene, and this always goes without saying. Hand washing is essential to prevent the spread of the virus to others, and we know this now, not only with flu and viruses, but also with this COVID-19. We're going to wipe everything down. We are going to disinfect objects that we use frequently or surfaces that we touch. And we will avoid contact with others for up to 10 days after we begin our symptoms, or for at least after 24 hours after the fever has gone, because I want to make sure that I am feeling really, really well and on the mend before I put myself into contact with others. Because remember, this viral shedding will continue from 10 days and it can last up to several weeks. Patient education. We are going to teach them to report worsening shortness of breath, change in amount, color, and viscosity of those pulmonary secretions, and if the fever comes back. Viral infections can be mild at first, but remember, they can rapidly progress to a viral pneumonia, or they can develop that secondary bacterial pneumonia. So, listen up, please. You want to make sure that your client maintains adequate fluid intake. Insensible losses from tachypnea and fever, where that increased breathing, if I'm breathing a little quicker, I can get more oxygen into my body, and if they're having a fever, that is insensible fluid loss. And this can lead to dehydration and thickening of those pulmonary secretions, which is going to make it difficult for them to cough and expectorate them. Medication education for the expected or the desired effects, any side effects, and then the expected duration of treatment. They need to know how long they're going to take their medications. So they need to know to take all of those antiviral medications if they are prescribed. Make sure to educate your client to take all of their medications even if they begin to feel better. They need to stay the course. They need to complete the course. Educate that the addition of antibiotics may be necessary for the occurrence because they have a secondary bacterial infection. They need to understand you're not taking this antibiotic because you have a viral infection. You're taking this antibiotic because you have a bacterial infection. We need to talk to them that these antiviral medications will not cure the flu. It will just shorten the duration and the severity of symptoms, and it will help prevent serious complications moving forward. And you will always, always educate them to get a flu vaccine every year, and strongly recommend this to also the family members that are living with them, because vaccination is the best method for preventing the flu. So, how do I know? How do I know that I've done a good job in taking care of this patient with the flu? Well, I won't have to take care of this patient with the flu if they have gotten a flu vaccine. So we need to talk to them and educate them about avoiding flu and getting a flu vaccine. So mild cases will usually resolve without any complications. Indicators of resolution are the vital signs are within the client's normal limits, not my normal limits, not yours, but the client's norm. They will have absence of fever for 24 hours after completion of their antiviral medications if they were prescribed. They will have easy respirations. They will be breathing easy. Their oxygen saturation will be above 92%, or it will be back to the client's baseline if they have an underlying comorbidity and they're not ever above 92. Absence of nasal drainage. There's no sputum production. They don't have a cough. And if they have had a chest x-ray, their chest x-ray is now clean. So, pneumonia. Here we are, pneumonia. Pneumonia can occur at any time and in individuals of any age. According to the CDC in the United States, there are approximately 3 to 4 million cases reported annually. Of these cases, 1/3 will occur in persons over age 65 years of age. The National Center for Health Sciences will report that older individuals, those individuals over 65 years of age, are at a higher risk of death from these respiratory infections. And so nearly 90% of all deaths from pneumonia are in this age group. So overall, approximately 60,000 deaths are attributable to pneumonia each year. It remains among the most frequent condition for which the death rate has not significantly declined over the past decade. Key risk factors for the development of pneumonia among the adult population include, but are not limited to, advanced age, long-term care residents, smoking, chronic respiratory disease such as asthma or emphysema, immune system dysfunction such as malignancy, or if your client has had a transplant, HIV, AIDS, altered mental status, prolonged immobility, aspiration of stomach contents, prolonged NPO status, exposure to air pollutants, and hospitalization for longer than 48 hours. So there is pretty much everything. Everything will predispose your client to pneumonia. Pneumonia can be classified into several types, and those types are listed for you in a table on page 447 in your textbook. Community-acquired pneumonia occurs in individuals who have not been recently hospitalized, or they are living outside of a healthcare or a long-term care facility. They are out in the community. S. pneumoniae is the most common causative organism. Few clinical studies have been able to confirm MRSA as a frequent cause of community-acquired pneumonia, but data to date may indicate that this incidence is escalating, and that is because they feel MRSA is becoming more and more predominant in the community. Methicillin-resistant community-acquired pneumonia results from a colonization of MRSA within the upper respiratory tract. And we remember this from when we were talking about infectious diseases in N112. So let's reach back into our brains for this information. Healthy individuals with no existing risk factors for MRSA colonization are being diagnosed with MRSA CAP, most frequently after experiencing a viral illness. Hospital-acquired pneumonia develops in clients after 48 hours of hospital admission. Pneumonia caused by atypical organisms is less often associated with mild respiratory illness. Healthcare-associated pneumonia diagnosis is made 48 to 72 hours after admission and is accompanied by the following risk factors. What you will see is your client on recent antibiotic therapy. They are receiving an immunosuppressive therapy. They may be diagnosed with a chronic disease. They have been treated within healthcare facilities such as dialysis clinics, adult daycare centers, rehab facilities, where they are in frequent close contact with healthcare personnel and other clients who may be colonized with various infection-causing organisms. So, what is pneumonia? Well, a pneumonia is an inflammation, here we are back with inflammation, of the lung parenchyma, functional lung tissue, resulting from bacterial, viral, or a fungal infection. Organisms will enter the respiratory tract through inhalation of infected droplets or aspiration from the oropharynx. They invade the protective mechanisms of the respiratory tract, and they will initiate this inflammatory process. So as the inflammatory process unfolds, protein-rich fluid and exudates again fill the alveoli, impairing the gas exchange of oxygen and CO2. So respirations will be impaired. Organisms can localize to one or more lobes. So you will see either a lobar pneumonia sequestered to only one lobe of a lung, or multilobar pneumonia. Or it can be spread throughout the lung parenchyma, resulting in the diffuse location of organisms. Bacteria causing pneumococcal pneumonia, S. pneumoniae, can gain access to the bloodstream, leading to septicemia and then septic shock. Elderly individuals over the age of 65 years or those with chronic illnesses are at high risk for mortality from contracting this bacterial organism. And here, if you're looking at the slide that I am looking at, in the right upper lobe pneumonia, you will see that the right upper lobe is just infiltrated with the pneumonia, whereas if you're looking on the right side, you can see that the pneumonia is more diffuse, spread throughout the lung. So clinical manifestations, what are we going to see? What is your client going to say? Clinical manifestations produced by the inflammatory response can vary from mild to severe, and they may include a fever, tachypnea, or shortness of breath. And this is where the client wants to breathe a little faster to get the oxygen into their body. But what's happening is that they continue to make themselves more short of breath. You will see tachycardia. They will have chills. There may be a cough, either productive or non-productive. They may have pleuritic chest pain. They are going to feel tired. They will have malaise. In more severe forms, some additional manifestations may be purulent or blood-streaked sputum, where that sputum is discolored, it's a yellow-green, or from coughing, it will be blood-streaked. Hypotension, and they may have a dysrhythmia. So, awareness of the clinical manifestation and predictors of increased mortality is essential to help ensure the speedy identification and then treatment of this pneumonia. The Infectious Disease Society of America and the American Thoracic Society guidelines for CAP in adults validated clinical predictors of increased mortality and morbidity from severe infectious pneumonia, which include an altered mental status, a respiratory rate greater than 30 breaths per minute. They may be hypotensive, which is systolic blood pressure less than 90, heart rate greater than 125 beats per minute, body temperature less than 95 degrees or greater than 104. Their arterial pH will be less than 7.35. Their serum sodium level will be less than 130. Their hematocrit will be less than 30%. Their PaO2 will be less than 60 on supplemental oxygen, greater than or equal to 40%. And there will be a presence of a pleural effusion on their chest x-ray or on their CT scan. So, diagnosis. Diagnosis is based on laboratory and then imaging studies. Lab findings may include an elevated WBC count, leukocytosis with elevated bands on the differential. So you're not only going to be looking at the WBCs, you are going to be looking at that differential. Elevated C-reactive protein level, which is an accurate, sensitive, and historically used test to detect the presence of inflammation and infection. ABGs will typically reflect a primary respiratory acidosis with hypoxemia. So there will be an elevated CO2, a decreased PaO2, and a decreased pH. Respiratory acidosis. Sputum cultures will reveal a preliminary category of the offending organism by gram stain, and then confirm the specific organism after 24 to 48 hours of incubation in the lab. Imaging. Imaging studies will show chest x-rays may or may not show infiltrates and can be up to 72 hours behind in revealing an infectious process. So that's when we have to look at the patient and we have to look at the lab studies. CT scans, however, of the chest may better demonstrate consolidation, which is solidification of the lung tissue, and the presence of pleural effusions. So again, prompt diagnosis is essential in providing timely and then effective treatment. So dependent upon the type of pneumonia, an early diagnosis and then the overall health of the client will determine treatment. So if uncomplicated, treatment can be effectively done in the outpatient setting. In more severe cases, it may require hospitalization and then supportive care. So due to the possibility of hypoxemia, administration of oxygen to reverse or prevent hypoxia is an essential first step. Ensuring adequate hydration is also an important intervention to support the client's cardiovascular status and assist in thinning those respiratory secretions for easy expectoration. So they either have to drink these fluids or they will have to have IV fluids because we want to supplement their cardiovascular status, right? We want to make sure that we can maintain that blood pressure and prevent those dysrhythmias. And we also want to thin those secretions so that they are able to cough them out. Medications, again, we are back with the bronchodilators. Bronchodilator therapy with albuterol, which is a short-acting selective beta-2, or Combivent with a slow onset of anticholinergic agents delivered either by aerosol nab or by metered dose inhaler will open up and promote ease of breathing. It's going to open up those airways and the patient will be breathing easier. Antibiotic therapy, the definitive treatment is based on the offending organism. And initially, a broad spectrum antibiotic is going to be initiated and initiated promptly. And then if we have cultures, we can change the antibiotic to the specific organism. Severe MRSA, community-acquired pneumonia, can lead to a necrotizing bacterial pneumonia requiring the client to go to hospital. A necrotizing pneumonia will result in fibrosis and scarring of the lung tissue. Pulmonary fibrosis and pulmonary hypertension from severe pulmonary infections can impair lung function after the respiratory infection will resolve. So acute meningitis can occur as a complication of a pneumococcal pneumonia. Empyema, a collection of purulent material in the pleural space, should be drained by the insertion of a chest tube. Other significant complications of pneumonia can be bacteremia, which is bacteria in the bloodstream, atelectasis, a complete or partial collapse of the lung that is more typically seen in the postoperative or in the immobile client, septic shock, and acute respiratory failure with multiple organ failure. So nursing interventions, what are we going to do? We are going to assess We are looking at neurological function, agitation, restlessness, anxiety. Listen up, ladies and gentlemen. Neurological function, agitation, restlessness, anxiety, lethargy, fatigue are the result of decreased tissue perfusion with altered alveolar gas exchange. There can be no gas exchange at the alveolar level because this is where the problem is with this client with pneumonia. So therefore, there can be no tissue perfusion. We are looking at vital signs, tachypnea, tachycardia, decreased oxygen saturation. We are seeing fever. Breath sounds, we are going to look at peripheral pulses and skin temperature and color. We are looking at respiratory secretions. Lab testing, we're going to look at that sputum microbiology. We are going to look at ABGs. Your client is going to be on I&O. Pulmonary hygiene, we are going to instruct on incentive spirometry, coughing and deep breathing, postural drainage, vibration and percussion. These are things that are done by physical therapy. No, I'm sorry, not physical therapy, respiratory therapy. Respiratory therapy will be responsible for the postural drainage and vibration and percussion if necessary. Early mobility, pulmonary hygiene is done in an effort to mobilize respiratory secretions and to allow expectoration. Patient positioning. So for infiltrates of only one lung, when turning and positioning your client, you will position them with the good lung down to maximize the ventilation and the perfusion of functional alveolar units. You will administer humidified oxygen as ordered, and because your client is on I&O, you will monitor that intake and output. Activity grouping, you are going to talk to them about energy conservation. You will approach activities of care with intervals of rest. Fatigue and decreased tissue oxygen delivery will limit their activity tolerance. So they need to do a task, rest, do a task, rest, and then administer antibiotics as ordered. Patient education. Patient education for this client will include hand hygiene and respiratory etiquette, washing hands after blowing a nose, throwing away our tissues. You will ensure that they get adequate rest. They will take all of their antibiotics as prescribed, and you will stress the importance of finishing all medications, even if the clients begin to feel better. They need to stay the course. They also need to know that antibiotics will not cure a bacterial infection. It will battle the infection. Encourage proper nutrition and adequate fluid intake. Please understand, listen up, listen up, listen up. You will teach the client that understanding of signs and symptoms indicating worsening respiratory status, they need to seek medical attention. So if this is a client who is dealing with their pneumonia at home, they need to know those signs and symptoms that will indicate that they are getting worse and when to come back to hospital. And then you will encourage at-risk clients to get a pneumonia vaccine every 5 years. So how do I know? How do I know that I have done a good job in taking care of this client? Clients with mild cases of bacterial pneumonia are successfully managed as outpatients or oral antibiotic regimens. Most clients with pneumonia requiring hospitalization will fully recover from their illness and they will be discharged without complications. Okay, so ladies and gentlemen, we are now going to talk about tuberculosis. Tuberculosis TB is a significant and potentially life-threatening respiratory infection caused by the organism M. tuberculosis, which is an aerobic acid fast bacillus, an AFB. It will affect approximately 1/3 of the world's population. The CDC monitors the prevalence in this United States, and there has been a decline of new cases in the last 10 years. A persistent problem in the homeless and incarcerated populations, and persons infected with HIV or who have AIDS are at exceptional risk of contracting TB or activating latent TB, which is a leading killer of people with HIV infection. So, TB is typically transmitted by aerosol droplets, which is inhaled from the coughing and sneeze of an infected individual. Same like we've been saying with flu, pneumonia. Droplets are tiny, and they can remain suspended in the air for several hours. So in close contact situations, those with infected sputum are most likely to transmit this infection. So bacilli that invade the mucociliary escalator defense, remember we talked about this way back at the beginning of this lecture, are deposited within the alveoli, and they are quickly engulfed by the macrophages. So once they are ingested, there is a slow but continued multiplication of the bacilli. So TB has classifications, and latent tuberculosis is classified as LTBI. Primary tuberculosis infection, PTBI. Primary progressive TB infection, PPTBI, and then drug resistant, which is MDR-TB. So diagnosis is made by laboratory testing, a skin test, and then a chest x-ray. Laboratory testing will consist of a sputum test for culture and then acid-fast staining. The skin test is a positive purified protein derivative, that PPD, and we are also all acquainted with the PPD, right, because we get them to check. It's also called a Mantoux test, which is the standard method for determining if an individual is infected with the TB-causing organism. So listen up, ladies and gentlemen. Treatment. Goals of treatment are to cure the client and to minimize transmission to other persons. The goal of TB treatment is to cure the client and to minimize transmission to other persons. There is a basic 4-drug combination that is recommended and should continue for 9 to 12 months. And this is a problem, right? Because it's a very, very long time. It is a very, very long treatment. So after some months, after a period of time, your client is going to beginning to feel better, and they are not want to go into continued treatment, but they need to do the full course of treatment, which is 9 to 12 months. Basic treatment is broadly acceptable. However, modifications may be necessary in special circumstances, such as a client that is HIV positive, if they are pregnant, if they are drug resistant, or if they are a child. So complications of TB. Extensive respiratory tissue destruction can lead to respiratory failure, bronchopleural fistula formation. A bronchopleural fistula formation is an air-filled sinus tract that will develop between the bronchus and the pleural space. Pleural effusions are also a complication, and a pleural effusion is a collection of fluid in the pleural space. Extrapulmonary TB can present as meningitis, lymphadenopathy, a bone disease, and then liver and kidney failure. Nursing management. Unexplained weight loss, night sweats, fever, chills are seen as a result of the inflammatory response. Rusty-colored sputum. Rusty-colored sputum is a hallmark sign of a client with TB, and this will occur as a result of the destruction of lung tissue during the granuloma formation. They may have pleuritic chest pain as a result of chronic coughing. Nursing interventions, we will assess. We are looking at their temperature because fever is a result of the inflammatory process. We are looking at their sputum. It will be blood tinged or rusty colored. We are listening to breath sounds. Wheezing from irritated airways producing bronchospasm, rales, and rhonchi will be from fluid and then fluid exudate. We are looking at their oxygen saturation. Decreased oxygen saturation will occur with the destruction of lung tissue, lessening surface area for air exchange. So what are we going to do? Nursing actions for this client. This client will be on isolation. TB is an extremely contagious disease. Therefore, your client will require a negative airflow room. If this client needs to leave the room to go to X-ray, to go for testing, they will be wearing a mask. A mask is required to transport this client. Listen up, listen up, listen up again. TB is an extremely contagious disease. Your client will be wearing a mask to be transported. You will also require eye protection to do care with this client. Humidified oxygen to maintain the integrity of the mucous membranes. You will ensure adequate nutrition. Clients may report substantial weight loss because they are not hungry. During the time prior to the diagnosis, this condition will affect their appetite. You will administer antibiotics as necessary. Listen up, listen up, listen up. Patient education for this client. You will stress the importance of skin testing for individuals that are living with this infected person. Because this is an extremely contagious disease, everyone that is living with this client needs to be tested. Ensure that the client and the family understand the importance of completing all of the medication regimen. And please remember, it is 4 medications, a combination of 4 medications, and they must be taken from 9 to 12 months. You will assess the client support systems and then the community resources that will ensure successful adherence to the treatment plan after your client goes home. Listen up, and listen up one more time. Evaluating care outcomes. How do I know? How will I know that I've done a good job with this client that has TB? Successful treatment will require early detection and a comprehensive multidisciplinary structure that will address the clinical, the psychosocial, the environmental, and the financial issues. TB is all-encompassing. It is all-inclusive. This client may not be able to work. That will have an impact if he is head of family. If the whole family has been contaminated and is infected with TB, then that means everyone is undergoing this treatment for 9 to 12 months. So because of the long treatment period, the client needs to be encouraged to follow the prescribed plan of care after being discharged into the community. So, indicators of resolution are the ability of the client to gain and maintain a stable body weight, improved skin turgor, good muscle tone. There will be absence of cough and no sputum production. They are breathing easy. There are no more fevers and no more night sweats.